Okay, so we can move to the first talk from Rossella Elisei, Advances in Thyroid Cancer Classification and Molecular Genetics. Please.
Good morning, everybody. Thank you, Laura. Well, in the last 10 years, a great number of information we obtained from studies like this one, that is one of the most important, about the landscape of genomic alterations in thyroid cancer. This study was dedicated totally to well-differentiated thyroid cancer, particularly to papillary thyroid cancer. The authors analyzed almost 500 differentiated thyroid cancer, looking at genomic alteration. As you can see here, in the upper part of the panel, the most frequent genetic alteration in papillary thyroid cancer is BRAF mutation, which represents almost 60% of all mutation. Then we have several cases with RAS mutations. These are the cases. And then there are other cases with RET or other gene fusions. As you can see, they are characteristically mutually exclusive, or BRAF, or RAS, or rearrangements. According to this study, the cases were distinguished into two major groups, the BRAF-like and the RAS-like tumors. BRAF-like are less differentiated and more aggressive with respect to the RAS-like tumors, which are less aggressive and more differentiated. And this is a very important differentiation that is taken into account even in the last and new WHO classifications, in which the tumors, the papillary thyroid cancer particularly, must be distinguished in BRAF-like and RAS-like cases. Almost 60% of papillary thyroid cancer are BRAF positive and 13% are RAS positive. Which is the clinical relevance of this information? Nowadays, BRAF, but not RAS, unfortunately, is druggable. So we can use drugs specific for cases with BRAF mutation. So it's very important to know if this mutation is present in the tumor of our patients. Also, poorly differentiated and anaplastic thyroid cancer have been deeply analyzed for genetic alterations. You can see here a big number of poorly differentiated thyroid cancer, and here several anaplastic thyroid cancer. What you can see is that in both cases, BRAF mutation is still present at a relevant percentage, 32% in poorly differentiated and 45% in anaplastic thyroid cancer. So again, these tumors can be treated with drugs that can act against BRAF. However, in this tumor, it is important to say that there are other simultaneous alterations like TERT, as you can see here, very frequent both in poorly differentiated thyroid cancer and in anaplastic, and in anaplastic also TP53. And the drugs that we can use for the treatment of these patients with BRAF mutation is a combo of a BRAF inhibitor and a MEK inhibitor, respectively dabrafenib and trametinib. And this is the study that demonstrates the effectiveness of these drugs. You can see here the results of the shrinkage of the lesions that was really relevant in the majority of cases, and also the duration of the treatment. So these drugs nowadays are very useful for the treatment of these cases. There is also a subgroup of papillary thyroid cancer harboring fusions, gene alterations due to the rearrangements of genes. Several genes can be rearranged, but we are more interested to the rearrangements of TRAC and RET. Again, because nowadays we have drugs that can act against these rearrangements. Unfortunately, they are not so frequent. As you can see, TRAC rearrangements are present in about 2-3% of cases, and the RET rearrangement in about 6-7% of cases. But in any case, it is important to look at the presence of this alteration because drugs are really very well working. And these are the results of Libretto 001, in which selpercatinib has been tested against these fusions. This is the waterfall of a group of cancer derived from follicular cells, papillary, poorly differentiated, anaplastic, and uterus thyroid cancer cells, in which you can see the response was really very impressive. The majority of cases showed a partial response, even a complete response, and the others had a stabilization of the disease. So really impressive response. And this is pralsetinib, again, another very specific anti-RET inhibitor. And these are cases of papillary thyroid cancer with fusions, different fusions, as you can see here, and according to the color. But all of them had a very relevant response to the treatment with the drug. Larotrectinib is the specific anti-TRAC. So cases with the TRAC fusions can be treated with larotrectinib, and these are the results of the study. You can see here several cases of papillary thyroid cancer and poorly differentiated thyroid cancer and follicular thyroid cancer. And you can see that the response was in the majority of cases a partial response, even a complete response. And this is also impressive regarding the anaplastic thyroid cancer, in which not all, but at least half of them had a very good response. And this is the duration of the treatment that is, in any case, very significant. Also, entrectinib can be used against TRAC. Entrectinib is not specific for TRAC, but it can act also against ROS1 and ALK gene rearrangements. And the drug has been tested in a basket study in which different types of human tumors harboring these mutations were included. Among them, also some thyroid cancer, here in yellow and indicated by the red arrows. And as you can see, in all cases, we got a very good response to the treatment. What about medullary thyroid cancer? This is the genetic landscape of a somatic mutation of a cohort of medullary thyroid cancer of almost 200 cases. And as you can see here, in the majority of cases, there is a RET somatic mutation, mainly the M1918, the most famous RET alteration, but then we have also other RET point mutations. These are not fusions, these are point mutations, and they represent about the 60% of cases of mutation in medullary thyroid cancer. Then we have a subgroup of cases with RAS mutations, also almost 24%, and still a portion of about 15-18% of cases in which so far we do not know which kind of mutations are there. And it is interesting to observe that RET somatic mutations are even more frequent if we select the subgroup of cases that are advanced. So if we look at the advanced cases, those that need systemic therapy, the RET mutation is present in almost 90% of cases. Only a minority of them have no apparently genetic alteration. And very recently, and I want to share with you this information, we also find a biallelic inactivation of NF1 that is known as a tumor suppressor gene, and it can play a role in some cases of medullary thyroid cancer. These are the results of Libretto 001, in which selpercatinib was used, as I said before, in RET-alterated cancer. Here are the medullary thyroid cancer panel A cases that were previously treated with vandetanib or cabozantinib or both, and in panel B, naive patients. In both cases, you can see that the response to the drug was impressive, even with the complete response, majority of cases with partial response or stabilization of the disease. I just remember that these patients were all in progression when entering the study. So the stabilization of the disease was indeed a good response. And these are the results of pralsetinib, the ARROW trial, the other RET-specific inhibitor, in which upper panel represented by cases that were treated with other drugs before, or the naive cases. And the color represents different mutation of RET. You can see that the majority of them, if not all, respond very well to therapy and also independently from the type of mutation. How to search this genetic alteration and when to search these alterations? This is the real question right now. When is something that we are still discussing, for sure when they need systemic therapy. How? There are several different methods. We can use simple Sanger sequencing if we look at one single or few alterations. We can even use new, very sensitive methods like digital PCR if we have few amount of DNA and we need to enrich the search. But for sure, the most important and the most complete type of analysis is next generation sequencing, in which we can simultaneously analyze in the same samples of DNA or RNA all the alterations that we are looking for. So in conclusion, although not yet fully discovered, the genetic landscape of papillary thyroid cancer, poorly differentiated anaplastic and medullary, is now widely understood. Several molecular alterations are actionable with targeted drugs that can have a clinically important impact on disease outcomes. Molecular analysis of tumor tissue should be performed as soon as possible, at least in patients with advanced and progressive disease who will require a systemic therapy. In thyroid tumors derived from follicular cells, BRAF is the most frequent alteration and should be studied first by immunohistochemistry. I forgot to say this, but BRAF can be easily analyzed on the tissue by immunohistochemistry and is very quick analysis. Negative cases should be analyzed by NGS for all the other alterations, particularly RET, TRAC, ALK, and BRAF fusions. In thyroid tumors derived from parafollicular cells, RET is the most common alteration and should be tested for first. NGS is the best approach since it allows to analyze the full gene because the mutation of RET are spread all over the gene. And I thank you for your attention.